Vishnu, start.
Yes, sir. Okay, sir. So, good evening to all faculty and colleagues. I'm Dr. Vishnuvardhan from Wednesday Surgical Unit. I'm going to present acute deep vein thrombosis and its management under guidance of Dr. P.R. Modi sir and Dr. A.G. Shah sir and Vineet Chauhan sir and Maulik Mehta sir and Hardik Bhatt sir. So coming to the definition, deep vein thrombosis, or DVT, is defined as the formation or accumulation of a thrombus that blocks the lumen of a deep vein completely or partially. VTE, which is also called as, which is abbreviated as venous thromboembolism, it is a four-word definition as formation, development, or existence of a blood clot or thrombus within the venous system. The terms deep vein thrombosis and pulmonary embolism are included in the venous thromboembolism. When DVT occurs in the setting of a recognized risk factor, it is defined as secondary. When it occurs in the absence of any risk factors, which I'll be talking in the next slides, it is termed as primary or idiopathic. Coming to history of deep vein thrombosis, in 1810, Ferrier diagnosed a patient with phlegmatia alba dolens, but assumed it to be caused by lymphatic obstruction. Davies established the connection between phlegmatia alba dolens and acute deep venous thrombosis in 1822. Phlebography was first attempted by Berberich and Hirsch in 1923 by injecting strontium bromide into the veins. In 1938, Dos Santos in Lisbon described contrast phlebography in humans. By the end of the 19th century, proximal ligation of the greater saphenous vein, as described by Trendlenburg in 1891, comprised the surgical treatment of deep venous thrombosis. This included stripping of the saphenous vein by the early 20th century. In 1926, Bassi performed the first thrombectomy in a patient with axillary vein thrombosis. In 1937, Crawford first successfully used heparin in humans. Sir, anatomy of the lower limb venous systems. Sir, in the foot, the veins of the metatarsal veins on the dorsum, they are tributarized and form the dorsal venous arch, which continues superficially in the medial aspect as the great saphenous vein, and in the lateral aspect as the short saphenous vein. In coming to deep veins, the digital veins which form the deep plantar arch, the deep plantar veins on either sides travel upwards to form the posterior tibial and the anterior tibial arch veins, and then they simultaneously the superficial veins communicate with the deep veins at the level of knee joint to form the popliteal vein, and then the popliteal vein extends upwards to form the femoral vein, and the great saphenous vein joins near the saphenofemoral junction and continues upwards into the pelvis as the external iliac vein, and then by the tributary from the internal iliac vein, it becomes the common iliac vein, and then both the common iliac veins form the inferior vena cava. Sir, coming to etiology, etiology includes trauma, which includes fractures of the long bones. It can be simple fractures or it can be comminuted or multiple fractures, both open or closed. Severe muscle injuries, while avulsion injuries, road traffic accidents, which causes extensive muscle debridement and necrosis. Major surgeries, including the surgeries of the abdomen, pelvis, the hips, or the lower limbs. Stasis of blood, which occurs when the patient is confined to bed, when the patient is having a limited movement, or patient is sitting for prolonged periods with crossed legs in front of while he is walking or he is on long travel. Patients who are paralyzed, either hemiplegia or total paralysis. Chronic venous insufficiency. And hypercoagulability states, like patients who are on birth control pills, hormone replacement therapy. Sometimes patients might be on hormone replacement therapy for after postmenopause, and pregnant females up to 6 weeks postpartum. Other factors include past history of deep venous thrombosis or pulmonary embolism, and any family history of DVT or pulmonary embolism in the family. Age. Risk increases as the age increases, as the elderly age has been proven that they have a hypercoagulability state, and obese individuals, and catheter located in a central vein. And other factors include inherited clotting disorders, protein C deficiency, and antithrombin deficiency. Explaining the risk factors of deep venous thrombosis briefly. Age. So venous thromboembolism occurs in both the young and elderly. Though higher incidence is associated with advanced age, it is also evident that children less than 7 years of age are associated with increased risk for deep venous thrombosis. The risk factor for age may be related to an acquired pre-thrombotic state, with aging of higher levels of thrombin activation markers, which are found among older people. Immobilization. Stasis in the soleal veins and behind the valvular cusp is aggravated by advancing age and inactivity of the calf muscle pump, both of which are associated with an increased risk of deep venous thrombosis. People who travel intercontinental flights or cross-country flights and people sitting in the economy class, they have a very limited leg room. And people
Vishnu, wait.
Yes, sir.
Please, Vishnu, please mute all. Everybody, please mute your audio. There is some disturbance going on from the wards. Please mute your audio. Continue, Vishnu.
Yes, sir. So travel, which is included as a risk factor, is due to immobilization due to prolonged travel in people who are traveling cross continents and cross countries. There is a syndrome called as the economy class syndrome, in which people who are sitting in the economy class in the flight cabinets are prone to more risk of development of DVT. If there is any previous history of venous thromboembolism, approximately 23 to 26% of patients presenting with DVT have a previous history of thrombosis. They are often associated with fibrous remnants of previous thrombi, which can act as a nidus and can progress to the formation of new thrombus. Patients who are in a patients with malignancy, a recognized malignancy is always found or mostly found in 19 to 30% of patients with deep vein thrombosis. Roughly 15% of malignancies are complicated by venous thromboembolisms. It is more often associated with tumors of lung, genitourinary and gastrointestinal systems. Limited association of risk factors is seen with other tumors, but DVT as an indicator of a previously undetected malignancy in patients with idiotic thrombosis. 5 to 11% of patients, malignancy appears within 1 to 2 years of presentation of DVT. Trauma as a risk factor. Recent trauma is associated with an almost 13-fold increase in the risk of thromboembolism. Certain subgroups are at particularly high risk of developing deep vein thrombosis. They include patients with elderly age, patients who are undergoing blood transfusions during surgery or prior to surgery, and patients who are undergoing major surgeries for the trauma and fracture of a long bone, either tibia or femur or spinal cord injury. And coming to surgery, high incidence of post-operative deep vein thrombosis is seen in patients who have underwent surgeries. The risk of deep vein thrombosis in surgery is determined by patient's age, coexistent thrombotic risk factors, type of procedure, extent of the surgical trauma, the duration of the procedure, and duration of post-operative immobilization. The overall incidence of deep vein thrombosis is approximately 19% in patients undergoing general surgicals and 24% in those having elective neurosurgical procedures. The greater risk of surgery, people developing deep vein thrombosis is seen in patients undergoing orthopedic surgeries. So this is a table showing the risk of post-operative deep vein thrombosis, which has been categorized by the characteristics seen in the patients. Patients who are categorized as low risk have characteristics of patient's age will be less than 40 years with no other risk factors, uncomplicated abdominal or thoracic surgery, and patients can be usually discharged within 1 to 2 days and are early mobilized. In the moderate risk category, the age of the patient will be 40 years and patient has undergone an abdominal or thoracic surgery of greater than 30 minutes, requiring immobilization for at least 1 to 2 days. And patients with high risk category are categorized as history of past or recent thromboembolism, patients undergoing abdominal or pelvic procedure for any malignancy, which can include staging laparotomies, and major lower limb extremity orthopedic procedures, which includes total knee replacements or total hip replacements or intramedullary nailings of any femur fractures.
So Vishnu, in those patients,
yes, ma'am,
and the patient who is going for more than 2 hours of the surgery,
yes,
most important things. So
yes,
if patient is undergoing the surgery which is more than 2 years, they are more prone for the development of the thromboembolism.
Yes.
Okay. And in pediatric patient particularly,
yes,
when child fall down from the cradle particularly, so at that time hanging of the upper limb into the cradle, which gives rise to trauma to the axillary vein, giving rise to the thrombosis into the axillary vein.
Yes.
Okay.
Oral contraceptives and hormonal replacement therapy is itself an independent risk factor for development of deep vein thrombosis. Even though there is an increase in the risk of thromboembolism after the cessation of oral contraceptives, seems to be a decrease in the risk, and it is independent of the duration of the use. Thromboembolic risk may be related both to dose of estrogen and type of progesterone used in contraceptive preparations. Currently, grade 3 or class 3 progestinogens are having a higher risk for thromboembolic risk development of deep vein thrombosis. Preparations containing less than 30 to 50 micrograms of estrogen are associated with less thrombotic risk, but development of deep vein thrombosis in the future period will be seen. Coming to primary hypercoagulable states, these refer to discrete genetic mutations and include inherited deficiencies of the naturally occurring anticoagulants, which are antithrombin, protein C, and protein S, and resistance to activated proteins. Coming to pregnancy and risk of deep vein thrombosis, women younger than 40 years are being associated with pregnancy are having higher risks of development of deep vein thrombosis. Patients who are who are primiparous after the age of 30 years have higher risk of development of deep vein thrombosis. Patients with pressure pregnancy.
Why?
Yes,
Why?
Ma'am, they have a increased estrogenic state, ma'am, because patients will be already on hormonal therapy for anti-fertility. They will be receiving anti-fertility treatment which contains estrogen modulators and estrogen receptor function drugs, which can increase the hypercoagulability state of the patient. In patient, when she is going to give birth via intrauterine fertilization or intrauterine insemination, there can be.
But what is the effect of estrogen on the vessel?
Ma'am, it causes endothelial damage will be more after estrogen, ma'am. So while during the delivery, there can be erosion of the endothelium and there will be damage to endothelium, which can cause development of thrombus in the deep veins.
Excuse me. Did you say anti-fertility treatment?
Sir, sorry, sir.
Yes, he said.
Sorry, sir. Anti-infertility treatment. Sorry, sir.
Fertility treatment.
Yes, ma'am. Fertility.
Particularly clomiphene citrate. Okay.
Good.
Thromboembolism during pregnancy and the puerperium is associated with higher rates of preterm delivery and perinatal mortality. Third trimester is associated with the highest thrombotic risk, and the risk of thrombosis appears to be 2 to 3 times greater during the puerperium, which includes puerperial sepsis. And during the delivery itself, if there is a delivery of the head, it can cause compression over the iliac veins while coming from the while there is delivery of the head, which can cause compression and it can lead to formation of deep venous thrombosis in the future period. Blood group as a risk factor. There is a higher prevalence of thromboembolism with blood group A and a lower prevalence in blood group O. Similar risk has been also attributed to blood group AB. Central venous catheters. The current or recent placement of a central venous catheter and previous placement of a transvenous pacemaker is found to be strongly associated with upper extremity DVT. And if they are placed transfemorally, there is also an increased risk of development of deep venous thrombosis in the lower limbs, with more than a 5-fold higher risk placed in the upper limb extremity DVT. The catheter material is an important determinant of thromboembolism. Other determinants of thrombosis are catheter diameter, number of venipuncture atoms, duration of catheter placement, and composition of the infusion. 65% of deep venous thrombosis cases are
Vishnu.
Yes, sir.
Vishnu.
Yes, sir.
You said material of the catheter. Can you elaborate a little?
Yes,
because
sir.
As far as I know, it is silicone or silastic. So, is there anything else available?
Catheters made of PTFE are also available, sir. And metallic catheters sometimes can be placed. And normal. Yes. Hello. Sir.
Yeah, no, but somebody else spoke something anyway. So I think what we put, they are all silastic. They are not. We don't use metallic central line, right?
Yes, sir. Depending upon in olden periods, sir, for doing CT angio, they used to place metallic.
See, that is why I'm asking. I don't know, Shrujal bhai, what do you say? Are there metallic these things available nowadays, or we use only for central venous?
But only thing, quality of material can matter. Whether it's a rough or large diameter catheter kept for prolonged time can affect. But otherwise, I am not aware about any particular material causing more DVT.
Okay. Fine. Thank you. Okay, Vishnu, go ahead.
Risk of development of deep venous thrombosis in inflammatory bowel disease. Venous thromboembolism is found to complicate IBDs in 1.2 to 7.1% of cases due to activation of coagulation, possibly due to endotoxin-induced monocyte activation. Varicose veins are superficial thrombophlebitis. Varicose veins serves as a marker of previous DVTs or venous stasis. Development of superficial varicosity is due to presence of past thrombi, which causes occlusion of the superficial flow into the deep veins, can cause varicose veins, which is a possibility of marker of previous DVT. Independent predictors of deep, they act as independent predictors of deep venous thrombosis. There is a higher correlation between DVT.
Vishnu, wait.
Yes,
wait.
Yes, ma'am.
Shrujal, you want to say something?
No, it's okay. This line, varicose veins serve as a marker of previous DVT, is not a right statement.
Okay,
it has to be changed. You will have a wrong impression. Varicose veins patients, out of, there is a 10% chance of increased DVT in patients with varicose veins, but they are not marker of previous DVT. Okay. Not all varicose vein patients will have DVT in past. Okay, yes. So it has to be corrected.
Okay.
Shrujal bhai, one question from my side. Hold on. I wanted to specifically, because I have come across one or two patients where they had DVT followed by varicose veins. The DVT has been resolved. Do they need treatment for varicose veins, or you should keep it as it is?
I usually don't advise, sir. They will be better managed.
Sorry. Vishnu.
Yes, sir. Yes.
Vishnu. अरे सबका ऑडियो म्यूट कर दो यार. Who the hell is this? आईसीयू में किसका पेशेंट है? Absolutely bogus. Sorry, Shrujal sir. Tell me.
So those kind of secondary varicose veins, they are better. In my practice, I manage with compression garment, and
right.
Actually, guidelines say that you can ablate those superficial veins if somebody is developing recurrent ulcer, and the deep veins are nicely patent, and all those veins have opened up. Otherwise, you should not operate on these kind of veins.
Right. Okay. So, and as such, I suppose they should not create problem, considering once the deep vein is patent, the flow should be that way, right?
Yeah, it's more of a patient's demand that I have varicose veins, you treat it. And if you burn these veins, if unfortunately patient develops second DVT, he will be in a big trouble.
Then I agree.
People do laser and RF, but I don't suggest particularly.
Right. Okay. Thank you.
Right.
Vishnu, go ahead.
Yes. So coming to the pathogenesis of development of deep venous thrombosis, Virtuous triad explains the pathogenesis of the development of deep venous thrombosis. Virtuous triad is a trifecta containing stasis, hypercoagulability, and vessel wall damage. Coming to the conditions which causes conditions of hypercoagulable state includes malignancy, pregnancy and peripartum period and postpartum period, patients undergoing estrogen therapy, patients who have suffered trauma or surgery of lower limb extremities, hip and abdomen or pelvis, patients with inflammatory bowel diseases, patients of nephrotic syndrome.
How the inflammatory bowel disease will develop stasis?
Ma'am, there is a monocyte mediated inflammatory conditions, ma'am, which can cause development of deep venous thrombosis.
So that is one thing. Other thing is because of the inflammation going on into the abdomen itself.
Yes,
that will give rise to thrombosis of the veins of the abdomen. That may give rise to also DVT. You have to see for the IVC thrombosis also simultaneously, or lymph node enlargement because of that. That also give rise to thrombosis there. Okay.
Coming to the vascular wall injury, trauma, patients who have undergone trauma or surgery, venipuncture, chemical irritation, heart valve disease or replacement therapies, atherosclerosis and indwelling catheters. Factors which cause circulatory stasis include atrial fibrillation, left ventricular dysfunction, immobility or paralysis of the patient, venous insufficiency or varicose veins, venous obstruction from tumor, obesity or pregnancy. Brief discussion about the pathogenesis. Endothelial damage occurs and then exposure of the tissue factor or subendothelial matrix which causes due to hypoxia. The receptors over the leukocytes causes activation are activated by the inflammatory cytokines interleukin-1 and tumor necrosis factor alpha. They express the tissue factor which internalizes the thrombomodulin and releases plasminogen activation inhibitors, which causes aggregation of platelet and delayed activity of tissue plasminogen activator, which causes congregation of the clot. And the further activation of coagulation due to inflammation, and then activation of monocytes and internalization of thrombomotilin and shedding of endothelial protein C receptors, which causes the coagulation cascade activation. Stasis of the blood flow in systemic circulation, immobilization pool of blood in soleal muscle venous sinuses, and which causes increased blood viscosity. In local blood flow stasis, hypoxia of the valve cusps, which are present in the veins of the deep veins of the lower limb, causes increased tissue factor and activates coagulation. Accumulation of clotting factors in the venous sinuses of the calf or valve cusp pockets. Coming to symptoms of deep venous thrombosis, patients may present with pain, which are tender, pain and swellings which are tender. They are warm. Patient might have complaints of fever, and patient has difficulty in flexion. The limb is red and discolorated. Distension of surface veins is sometimes seen, and patients who have symptoms of pulmonary embolism have difficulty in breathing, tachycardia or irregular heartbeat, chest pain or discomfort, anxiety, hemoptysis, and hypotension and lightheadedness. Images showing deep vein thrombosis and lower limbs, which is termed as phlegmasia alba dolens, which was initially thought to be due to the obstruction of the lymph vessels. And the second image is showing phlegmasia cerulear dolens, which causes a bluish discoloration of the limb, which is an acute condition. And signs which are elicited during the deep venous for deep vein thrombosis: Hohmann sign, Moses sign, and Neuhoff sign. In Hohmann sign, the sudden dorsiflexion of the passive dorsiflexion of the dorsum of the foot causes cramping pain in the calf muscles, which is a sign to elicited for deep venous thrombosis. In Moses sign, the palpation of the calf muscle causes tenderness. In Neuhoff sign, the deep palpation of the calf muscle, which causes cramping pain. Coming to diagnosis, there is
one minute.
Yes,
should we go for such signs, or can it lead to thromboembolism? Shujal bhai?
I was about to inform him that although these signs are important as a theory point of view,
yes,
practically we don't do, and squeezing or sudden jerky movement should not be done, right? They don't always give rise to embolism, but then if anything is mobile, it may traverse up. Okay.
yes.
And one more thing in symptoms,
Yes.
did you mention coughing? Was it there, coughing in PE? Just go back 2 slides.
Okay. Sir, coughing was not there, sir. Difficulty.
It is very common.
Go back.
Yes, sir.
No,
Okay,
okay.
It is very common. Coughing,
Yes, sir.
it will start with cough.
Okay,
Right.
sir.
So if
Yes,
we write in the files of the patients of DVT that if you develop cough or all this chest pain discomfort, you should
Yes, sir.
report to the physician. So you can include later on.
Okay, sir. Thank you.
So that is also a main symptom after the delivery also. In a
Yes, ma'am.
postpartum DVT with pulmonary embolism, because the mother is lying in the bed after the cesarean section particularly.
Yes, ma'am.
So she is not much ambulated, and because of that there will not be a edema of the feet in
Yes, ma'am.
initial stage. There may be a mild edema. It may be because of the preeclampsia,
Yes,
and so it is not noticed by the patient also. So cough post delivery is the first sign of the pulmonary embolism.
One more thing I would like
Yes,
to
sir.
add in the virtuous triad that in recent times you can add COVID as a hypercoagulable state, and we see lot of DVT and arterial thrombosis patients of who are affected by COVID. So now, because if you appear in exam and if you say, it will be a credit point that recently you know about recent things. Okay.
Yes.
Yes, ma'am.
But is it true for all other vessels also? Because autopsies have showed thromboembolism of pulmonary vessels. Is it true for other vessels also?
Sir, my father was affected, and when he was about to go on ventilator, he was there on BiPAP for 10 days. I thrombolized him without any evidence of pulmonary embolism. That means there are a lot of micropulmonary thrombosis.
Oh.
And I was, one of the very first who attempted this. And after that, a lot of patients, it have been tried, and that literally clears off the lungs. So you are right that it affects all the territories. We see mainly DVT and peripheral arteries because being a vascular surgeon, they come to us, but otherwise they are very much hypercoagulable, significant hypercoagulable.
Yes, we get one patient during the corona duty. That patient was operated for thrombectomy, and post-operatively patient developed fever, so they get the corona test again, and then he turned out to be a positive. So it's very common.
I became positive by operating a patient, man.
Yeah. Okay. Yeah.
Coming to the diagnosis, yes, ma'am. Coming to the probability, pre-test probability and combined diagnostic strategies, the well score, which is used to calculate the clinical probability of a person who can develop deep vein thrombosis. The well score is used to calculate. In the well score, each points are given for each character of the patient, which suggests the pre-test probability of development of deep vein thrombosis. The characteristics are patient presenting with lower limb trauma or surgery or immobilization in a plaster cast, bedridden for more than 3 days or surgery with the last 4 weeks, tenderness along line of femoral or popliteal veins, not just only calf tenderness. The limb which is entirely swollen, the calf which is more than 3 centimeters in circumference when compared to the opposite calf and 10 centimeters below the tibial tuberosity. There is presence of pitting edema and dilated collateral superficial veins which are non-varicosities, past history of confirmed deep venous thrombosis and malignancy, including treatment up to 6 months previously. All these attributes are given a score of 1, and intravenous drug use is given a score of 3. Alternative diagnosis as more likely than DVT, which can be used to deduct 2 points from the well score. And so the score will be interpreted as the patient is at high risk of development of DVT. If development of DVT or patient with ongoing vascular thrombosis, if it's greater than 3, and if the score is 1 to 2, then the patient has a moderate DVT risk, and if the score is less than 1, then there is low DVT risk.
Vishnu.
Sir, yes, sir.
Vishnu.
Yes, sir.
Go back. Intravenous drug use or drug abuse? What is it?
Sir, drug use and drug abuse also. Sir. Patients who are usually taking...
You are not getting my... that is, yes, you mean to say those drug who abuse. Are addicted to...
Yes, sir.
Yes. So, I mean... so it's a drug abuse, right?
Yes, yes.
Who gets high by IV injections?
Yes, sir.
Right. Okay. So
Sorry.
You said something, sir.
Vishnu,
yes, sir.
Where did you get this well score and the intravenous drug use? You took it from textbook?
Sir, from the ACCP guidelines, there was one article, sir. I just found it in that.
Okay. Somehow, when we were studying, I was not sure about this +3 score of drug abuse, and I just checked online also. It is not coming in one of the articles. So yes, we will go back and we will check it out. Okay.
Yes. Okay.
You can also recheck, and I will also check it in my.
Yes. Yes. Sir, coming to lab investigations, when a patient presents in the emergency department or lands up in the outpatient department, so prothrombin time, INR, and D-dimers are done. These prothrombin time and international normalized ratio are assays evaluating the extrinsic pathway and common pathway of coagulation. Prothrombin time is often used in conjunction with activated partial thromboplastin time, which measures the intrinsic pathway and common pathway of coagulation. D-dimer is the degradation product of cross-linked fibrin by factor 13. It reflects ongoing activation of the hemostatic system. The reference concentration of D-dimer is less than 250 and less than 0.4 micrograms. They have low specificity for DVT, therefore they should only be used to rule out DVT, not to confirm the diagnosis of DVT. Since many other medical conditions which cause clot formations can also show a positive D-dimer value, which can be misinterpreted as patient is having a deep venous thrombosis. Sir, coming to other investigations, invasive, non-invasive duplex ultrasonography, or sometimes termed as compression ultrasonography without any motion M mode. Venous duplex ultrasonography is currently the most widely used diagnostic test for acute DVT. Coming to invasive tests, there is venography, which was previously considered the gold standard investigation.
Vishnu.
Yes, sir.
Go back to the DVT side. What is your picture showing? Can you show us the interpretation of the picture?
Yes, sir. Sir, this is the
See, I
human.
agree that duplex is very important, but
Yes.
what do you see in the duplex?
Yes, sir. Sir, in duplex we see the in the B mode we see the anatomy, the patency of the and the thickness of the vessel wall, sir. And then in M mode we see the flow, and then the Doppler perceptibility, and we see the velocity of the flow, sir. In this image, the patency of the wall is present, but the Doppler perceptible flow shows that there is only peripheral trickling of blood which is flowing around the thrombus. And there is a avascular segment present within the vein, which suggests possibility of thrombus.
Loss of compressibility.
Yes, sir.
It's
Loss
very
of
simple.
Yes, sir.
In
Yes.
axial section, if you can't compress the vessel and if it remains round,
Yes, sir.
so that is thrombus, right?
Yes, yes.
And in color flow, loss
Yes,
of wall-to-wall physicity, color,
Yes, yes, sir.
right? So
Yes, sir.
that is indicative. But even B mode, you can diagnose. We being vascular surgeons, it's very easy to diagnose. Even you can see DVT, right? Go ahead.
Sir,
Okay,
yes,
fine.
venography, it was previously considered the gold standard investigation for confirming acute DVT. A venous catheter is placed, and then usually a iodine-based dye is injected, and then under fluoroscopic guidance or X-ray guidance, the patency of the vein was checked. Absence of flow from the vein, and if was confirmed to be having patient is suggested to have a deep venous thrombosis.
Is it done nowadays? Have you seen
Ma'am,
any
no,
journal?
ma'am. Nowadays it is not used now.
Because you are saying all details about the venography and not about Doppler.
Yes,
See,
ma'am.
nowadays we are doing Doppler mainly. So only thing is you have to see the Doppler study. That is the main thing. Huh? Okay.
Computed tomography, venography, in which dye is injected, and then computerized axial cuts and sagittal cuts of the CT plates are then taken and reconstructed to see the thrombus extension of the thrombus and the site of the thrombus. MR venography is done in patients who are where CT venography is contraindicated, and patients who are in second and third trimester of pregnancy. MR venography has a better specific and sensitive value for diagnosing the
What is the indication of MR venography?
Yes.
Specific.
Ma'am,
Yes.
yes, ma'am. When patients who are in acute kidney injuries and patients cannot undergo CT venography, or patients who have
Why do you want CT venography then when you can diagnose from Doppler?
ma'am, patients who
I
have
think
extensive raw areas where Doppler ultrasound probes cannot be placed.
I think I'll put the same question to Sujal bhai. The only thing is, if I think you need some kind of active intervention, I think then this will be required. Sujal bhai, what's your take, sir?
Shall I answer?
Yeah, that's for you only.
Yes, sir.
Yeah, it is for you only.
So nowadays, venography, this ultrasound and venous Doppler is considered gold standard. You can diagnose any DVT with that, right? CT venography and MR venography are not done. CT venography is reserved for those chronic post-thrombotic syndromes where you are expecting a chronically occluded venous segment and you have to offer venoplasty or venous stenting for that. So CT is any day better than MR venography. Most of the places CT venography is done. And as you said, a patient having renal dysfunction, MR venography would help. But even in CT, we inject iodinated contrast. In MR venography, we have to inject gadolinium-based contrast, right?
Yes,
so that will affect kidney even in a worse manner. So both of them are dangerous for kidney patients, and that's why you need not put the patients at the risk of any venography. These are reserved particularly for intervention and chronic patients where you are expecting, length of the segment, diameter of the segment, all these things. Only you should get this kind of test. Otherwise, not required. Yes. Okay.
So
in pregnancy also MR venography
the same question.
Usually when patient is already having pregnancy, do not require any surgery at that stage. So I don't think MR angiography in pregnancy is important.
Yes.
Right?
So one extended question for Sujal bhai. What is the indication of intervention? We routinely get many patients of DVT
Yes.
hardly there is a patient who requires intervention. Most of them do well conservatively.
Yes.
So as a general surgeon, it is a little limited to conservative management. So
Exactly.
what are the indications? What are the indications where you need an intervention, surgical intervention in a patient with DVT?
Okay. So the interventional therapy for acute massive proximal DVT is catheter-directed thrombolysis. When you are expecting common iliac segment or any floating thrombus in IVC, which has very high risk for pulmonary embolism, in such patients, you may offer catheter-directed thrombolysis because these are the patients who are at more risk of chronic post-thrombotic syndrome in future, right? So DVT is anatomically divided into iliofemoral, femoropopliteal, and soleal or calf vein DVT. So the iliofemoral DVT or proximal DVT with massive limb swelling, we can consider for thrombolysis. I used to do it in 2012 and 13 when I was a new vascular surgeon in Ahmedabad. In your early practice, you know a lot of theory, and then once I realized that doing thrombolysis may not be required for all these patients, so we reduced the number of these thrombolysis cases, right? But yes, the classic indication would be massive DVT and severe edema not responding to anticoagulation. Secondly, if somebody has presence with phlegmasia alba or cerulear dolans, we can offer thrombolysis or open venous thrombectomy. In my practice, these are the two classic indications. Third is floating thrombus in IVC with risk of pulmonary embolism, or somebody has already developed some cardiac issue and then there is a floating thrombus in IVC. You may put a filter and thrombolyze that segment. Otherwise, most of the cases in my practice, 99 out of 100, I would treat with conservative management, sir. Same as yours.
Thank you. Thank you. I think we'll go there also, but I just wanted to ask. Okay, thank you. Vishnu, go ahead.
So this is the algorithm for diagnosing the patient with deep vein thrombosis. If you are having a clinical suspicion for DVT, then well score is to be applied. If the score is less than 1, then a lab diagnosis of DVT, prothrombin and INR for baselines are to be sent out. If the D-dimer values turns out negative, then DVT can be straight away ruled out in patients with low risk well score. If the D-dimer is positive, then the proximal leg ultrasound is to be done. If the ultrasound is positive, then the patient will be diagnosed as having a deep vein thrombosis. If the ultrasound is negative for any proximal venous thrombosis, then DVT is ruled out. If the well score is greater than 2, patients with moderate risk, first straight away we go for proximal leg ultrasound. And if the ultrasound is negative, we send a D-dimer. If it's positive, then repeat ultrasound in 1 week. And if it comes positive, then the patient is diagnosed as having DVT. If the D-dimer which is positive and the ultrasound which is negative after 1 week, then DVT can be ruled out. If the patient's ultrasound is positive in a patient of well score which is greater than 2, then DVT is straight away diagnosed. In a patient with well score greater than 2, having ultrasound negative and a D-dimer test is negative, DVT can be ruled out. Classification of risk group of surgical patients and patient stratification. The risks are classified into low, moderate, high, and highest. When coming to patient stratification, low risk patients are stratified as having patients considered as minor surgery in patients aged less than 40. Moderate risk group is classified as minor surgery in patients with other risks. The other risks including previous surgery, trauma, patient who is immobile, patients having malignancy, patients who have undergone cancer therapy, patients of older age, pregnancy, having medical illnesses or cardiac or pulmonary failure, who are obese, who are smokers, having underlying coagulopathies and other disorders. The high risk group patients are stratified as age greater than 60 years or 40 to 60 years with other risks. The highest risk stratification group consists of multiple risk factors, which may include 2 to 3 of any of the risk factors which are mentioned. Sir, the risk factors are again classified. Score is given to each of the items represented. In group A, if there is a minor surgery planned and age of 41 to 60 years, history of prior major surgery 1 month back, and pregnancy or postpartum 1 month ago, patients having varicose veins, inflammatory bowel diseases, patient on oral contraceptive pills or hormone replacement therapy, patient who is obese and having swollen legs. each of the criteria which have been described in Group A are given a score of 1. And sir, age greater than 60 years, patients having malignancy
So Group
or
B is
undergoing.
two points, correct?
Yes, sir.
Group B
is
is 2 points.
Yes, sir. Group B is 2
And
points.
Group C is
Group C
3
is
points.
3 points, sir. And D is
Okay.
5 points, sir. So the total score of the
Oh,
risk stratification is calculated, and then they are again categorized into no risk, low risk, moderate risk, high risk, and highest risk. The DVT
okay.
incidence in
So,
yes, sir.
hmm.
DVT
Continue. Sorry.
DVT incidence in low risk level is 2%, and moderate risk is 10 to 20%, and people who have high risk level, the incidence of DVT is 20 to 40%. And people with very high risk, which is a score of more than 5, the incidence of DVT is 40 to 80%. And sir, the level of prophylaxis and management for low risk patients include no specific prophylaxis other than early and aggressive mobilization. Patients who are categorized into moderate risk, a low dose unfractionated heparin of low dose unfractionated heparin for 12 hourly or low molecular weight heparin of less than 3,400 units, and intermittent pneumatic compression devices are used in patient as a prophylaxis to prevent deep vein thrombosis. In patients with high risk patients under high risk category, low dose unfractionated heparin 8 hourly, low molecular weight heparin greater than 3,400 units with or without intermittent pneumatic compression devices are used as a prophylactic.
When will you start prophylaxis? When you are planning for surgery?
Ma'am, we can start for major surgeries, ma'am. It is started 14 to 15 days prior to surgery, and it can be stopped 12 hours before the surgery. If you are using low molecular.
The surgery?
Ma'am, for major abdominal surgeries and patients undergoing patients who are
surgery, it doesn't mean it requires 15 days prior to the surgery. Sujal, what will you say?
No, it's not required. There is some confusion. 14-15 days prior, there is no prophylaxis. You can give one shot of low molecular weight heparin 14-15 hours prior to the surgery if you are worried, right? If days is something wrong, correct it. It's not there. And
secondly, do you?
Yeah, sorry.
Sorry. Please continue, please.
This low molecular weight heparin less than 3,400 unit and more than 3,400 unit. Don't get confused by all this. If it is moderate or high risk patient, prophylaxis is very standard. Low molecular weight heparin, if you are giving enoxaparin, as per the weight, if patient is 60 kg, 0.6 sub-Q OD, that's all is your prophylaxis. So it is weight dependent. You have to give by weight, right? It doesn't depend on the risk that dose will change.
Yes, sir.
Okay.
Yes, sir. Yes.
Okay.
Yes, sir. So coming to treatment of deep venous thrombosis, the treatment modalities include anticoagulant.
1 minute.
Yes,
Go to the very high risk INR 223, right? Yes, so that is you have considered for prophylaxis. What is that?
Sir, patients who have INR of 223 and are already on anticoagulant therapy can be given as therapeutic and can be considered prophylaxis to prevent further progression of deep venous thrombosis.
This is actually a therapeutic dose range of
INR. Yes, sir.
vitamin K antagonist, right?
Yes, sir.
So yes, usually in prophylaxis, we feel heparin or any other newer oral anticoagulants are good enough for prophylaxis because keeping somebody on therapeutic range might not be required. So let's go to the therapy now. You can move there.
So coming to treatment of deep venous thrombosis, the modalities for treatment include anticoagulant therapy, thrombolysis, surgical interventions, and IVC filters. Sir, apart from that, limb elevation to avoid stasis in patients of acute venous thrombosis, prophylactic antibiotic coverage to prevent any further infections. And sir, coming to strict immobilization, there has been controversy for many years as to whether physiotherapists should walk the patient who have been diagnosed with acute deep vein thrombosis. But sir, recent systematic reviews examining bed rest versus early mobilization, there is no difference in risk between ambulation and bed rest for development of pulmonary embolism.
What do you mean by early ambulation?
Ma'am, after 5 days of initial
early ambulation. Early ambulation is immediately after surgery, after 24 hours, after 48 hours. What do you mean by early ambulation?
Sir, madam, he is in the therapy part. If for prevention part, early ambulations, I would prefer, same day evening or next day morning, that would be early ambulation. But in case patient has already developed DVT, vigorous physiotherapy or, ambulation is, in practice, we say 2 to 3 days they can do rest if they have a lot of edema. For those patients who don't have edema, there is no need for bed rest. They can use a compression bandage or stocking and start ambulation. So therapy part 5 days rest is only for those patients with massive edema, so that their edema comes down.
Okay, right, sir.
There is no difference in risk between ambulation.
Vishnu, go ahead.
Yes. So coming to anticoagulation therapy, composing both oral and injectables, remains the mainstay of medical therapy for DVT. It is a non-invasive procedure, treats most of the patients, and it has a low risk of complications and good patient compliance. So general considerations before starting anticoagulants: in a hemodynamically unstable patient with pulmonary embolism, and patients in whom we are suspecting pulmonary embolism and are hemodynamically unstable, we are not directly going to any surgical intervention or placement of IVC filters is much more better than starting the patient empirically on anticoagulants. And patients with high bleeding risk with acute proximal DVT or pulmonary embolism, an inferior vena cava filter might be placed if anticoagulation is not possible due to exceedingly high bleeding risk. Patients with impaired renal functions.
What about thrombolysis rather than you are saying about this?
Yes, ma'am. Thrombolysis again carries a higher bleeding risk at the local site. So, ma'am, they have suggested that inferior vena cava filters might be better when compared to anticoagulation.
So what will you say? In acute phase, what should be done? Shrujal?
Yeah, so that's what I discussed previously, that in majority of the proximal massive DVT, we will suggest thrombolysis. Otherwise, now newer oral anticoagulants are so good and patients come to us so early that we get fantastic result just by anticoagulant also.
Yes.
So thrombolysis is reserved for very selected patients. People do see, just because a lot of vascular surgeons know thrombolysis and it gives a procedure as well as revenue to the private practice. A lot of people do thrombolysis, but it should be reserved. In ideal practice, it should be reserved because you will see the same result at the end of 1 month.
वो आके देखेंगे फिर से और करना है इसको लगभग खुला ही रखेंगे.
Previously, people were doing before 5-6 years. People were doing thrombolysis so frequently. Nowadays, it is stopped again.
Not stop, madam. Actually, still a lot of people do, but there is no. See, people do it for even calf vein DVT, but there is no role of thrombolysis in calf vein or femoral popliteal vein DVT. It can be done for massive proximal venous DVT, where your limb is massively swollen, because you want to prevent this valvular damage and post thrombotic sequelae. But otherwise, this standard anticoagulant which has been used since years is good enough.
Okay.
So patients with impaired renal function with a creatinine clearance of less than 30 ml per minute, caution is indicated because low molecular weight heparin and particularly fondaparinum are likely to accumulate because they are not mostly excreted by urine. So then eventually they will result in an over anticoagulation.
Shrujal, what will you say about using heparin or LMWH in acute phase? What do you suggest?
Madam, as a medical part, both of them have same result. So I only if the renal function is deranged, I would go for admission and conventional heparin, that is unfractionated. Otherwise, low molecular weight heparin, or I would even prefer newer oral anticoagulants like rivaroxaban, apixaban, dabigatran. They can be started from very early stage and they have good result. So
is it having result? Because in orthopedic people, they are giving routinely after the THR and all these things.
Yeah, they have fantastic result. I am using since last 8 years. This Xarelto rivaroxaban has super result, so it can be used.
Okay.
One input I want, Dr. Shrujal Vaiki. The thing is, in the recent past, we have got some patients in whom, in spite of giving high doses of heparin as well as warfarin, we are not getting the required INR.
Yes.
What could be the reason, and how can we resolve the matter?
So, if you are giving heparin or low molecular weight heparin or fondaparinux, there is no need for checking INR because they work differently. When the patient is on vitamin K antagonist, warf and acetrom are these two molecules, right? So if somebody is
Yes.
not responding to warfarin, you may immediately switch over to acetrom. And if the response is not there with acetrom, there can be some resistance or so we have to change the molecule. We have seen that somebody is not responding with 10 mg of warfarin, and with acetrom 2 to 3 milligram we will achieve therapeutic INR. So we have
because this is we have practically faced. My residents would be ready to, because in last 2-3 patients we have given 3 milligram, 5 milligram of, when the patient has, even then we started acetrom, but they have not reacted well. That's why. So your newer drugs, do they act to those patients?
Yeah, actually they act, but there is no way to check their activity, sir. If somebody has not responded to warf and acetrom, that is very, very rare actually. And I would prefer them to switch over to rivaroxaban, but then you should not check INR and say that it's not working. We have to just forget it.
Okay.
Yeah.
So there was one question from the resident.
Yes.
How much time it take to get recanalized? I will say it's 6 months usually. It requires minimum 6 months. 3 months to 6 months.
That depends on how much activity patient does, what compression patient has used, is his or her hypercoagulable state, and which molecules are used. So with newer drugs, you will see around 3 to 6 months, as madam said. 6 months it will be maximum. After that, you should not expect further recanalization. But some people develop recanalization at the end of 3 months also, if they are active and they are mobilized.
Okay, go ahead. Vishnu?
Yes, sir. So coming to classification of the anticoagulant drugs, they are divided into direct thrombin inhibitors, vitamin K antagonists, and factor 10A inhibitors. In thrombin inhibitors, they are direct and indirect. In direct thrombin inhibitors, they are parenteral and oral. Coming to parenteral drugs, there are lipiridine, bivalirudine, and argobatro. And oral direct thrombin inhibitors are zimalagatro and dabigatro. In indirect thrombin inhibitors, it is heparin, which is again divided into 3 parts, which is unfractionated heparin, low molecular weight heparin, and danaparin. In vitamin K antagonists, there are coumarin anticoagulants, which is warfarin and acetylcholine. So factor 10A inhibitors, direct and indirect. The indirect, it is fondaparinux, and direct, it is apixaban and rivaroxaban.
Okay.
Coming to heparin, it is a cofactor for antithrombin and protease interaction without being consumed. In low doses, it inactivates the factor 10A, which inhibits the conversion of prothrombin to thrombin. In high doses, it inactivates factors 9, 10, 11, and 12 and thrombin, and inhibits conversion of fibrogen to fibrin. Dosage, onset is immediate onset. When given in subcutaneous, the time or duration of onset takes 20 to 30 minutes. It is mostly metabolized in the liver and reticuloendothelial system. The half-life is 60 to 90 minutes, and excretion is by urine. Coming to dosage of unfractionated heparin, for therapeutic doses, we
about heparin, I will ask, if patient develops some complication of bleeding, how will you combat with that complication in heparin?
Ma'am, stop the heparin and then we give a protamine sulfate as an which is
How
an
much?
anti.
How much?
Ma'am, protamine sulfate is given according to weight, ma'am. 10 mg per
it's
kg
a simple thing. If you do not remember, it is a simple thing. If usually we are giving 5,000 units 6 hourly, or we are giving 1,000 units daily in acute phase, every hour. Every hour, 1,000 units hourly, either by infusion pump or by IV method. So in that case, patients considering 5,000 unit, we usually give 100 milligram of protamine. So that is a routine dose. So immediately you have to stop and give protamine. That is sufficient for heparin. Now continue.
Dosage of unfractionated heparin. For therapeutic doses, intravenously we give a loading dose of 80 units per kg, and then infusion dose of 18 units per kg per hour. It can be given as a 5,000 international units loading dose, followed by an infusion dose of 1,300 units per hour. In subcutaneous dosages, 250 loading dose is given as 250 units per kg and 17,500 units. Or maintenance doses are given as 250 units per kg 12 hourly and 250 units per kg 12 hourly. For prophylactic doses of unfractionated heparin, it is 5,000 units subcutaneously 8th or 12th hourly, or 7,500 units subcutaneously every 12th hour. Coming to low molecular weight heparin, the prophylactic dose is 30 milligrams twice daily subcutaneous, or 40 milligrams once daily. Therapeutic doses, like Sir said, 1 milligram per kg twice daily, or 1.5 milligram per kg once daily.
Does it make any difference if we give heparin? See, we have got 6 hourly, 8 hourly, 10 hourly. Sujal bhai, what will be the ideal way of giving a heparin?
So for prophylactic purpose, this IV, hello.
Yeah.
So 5,000 sub to 8 hourly or 12 hourly should be fine. But usually nowadays for prophylaxis, nobody is using heparin. Sir, I'm not sure about a bigger institute.
Enoxaparin, yeah.
Enoxaparin, and what he has written 30 milligram twice daily or 40 once daily is not a right thing. Actually, if the patient is 100 kg, you may have to give almost 0.8, say that is 80 milligram once a day. So it is absolutely weight dependent, and prophylaxis is once a day, therapeutic is twice a day in case of low molecular weight. Same dose.
Right.
So same 0.6 milligram OD for prophylaxis and 0.6 milligram BD as a routine Indian people. 60
kg person.
Yeah. And about heparin, the same thing for heparin?
Sir, heparin, we usually in our practice we give only IV. This 5,000 bolus followed by 100 or 1,000 or 1,300 units per hour infusion, and we check it by APTT. So for this subcutaneous use of heparin is very much limited because many patients may be in shock and it may not be absorbed from abdomen. So we have to be very careful. Yeah.
Okay. Sir, there was a question from one of the residents that we do a Doppler after 6 months of DVT. The patient has developed recanalization but not complete. How long do we continue the anticoagulant therapy, or do we go for some kind of intervention?
Yeah. So what remains after 3 to 6 after 3 months is more of a perivenous fibrosis and intravenous VAPs. The clot will not be there for this much duration. So your continuation of anticoagulant may not help. The important thing is, if the patient is hypercoagulant and carries the risk of further DVT, you may consider for extended prophylaxis. Otherwise, acute phase DVT, the treatment is for 3 months, in selected patients 6 months, and then you have to stop. If you want to consider for longer therapy, and if in between you are stopping, you have to check D-dimer initially and compare further D-dimer. If it is in increasing trend, you may continue your prophylaxis. Right? Otherwise, there is no meaning in continuing DVT prophylaxis or therapy for 1 year or so, because they have bleeding risk. So there are very clear-cut guidelines. If you see ACC, ACCP, there are very clear guidelines about this.
So you have to counsel the patient when there is a limb edema, that you have to counsel the patient that you have to wear the stockings or elastograph bandages. That is the main thing. So
what remains at the end of 3 to 6 months is post-thrombotic kind of edema, and they will not that will not disappear with your medicine. That will disappear with 2-3 things. One is calf improvement, calf pumping exercise. Second is compression garment. Third is weight loss. If the patient is quite obese, they will keep on lingering to one specialist, then second, then third. They won't be satisfied. So your compression therapy and your weight loss will definitely help in this kind of edema, not the medicine. Okay.
Yes.
All right, sir. Okay. Vishnu, continue.
Sorry, one last thing, sir. In this particular question, if the iliac vein segment is occluded and patient has significant edema after 6 months, you can consider to open it by venoplasty at the end of 3 to 6 months. That is a separate decision if patient has significant edema.
Yeah, and proximal thrombosis.
Proximal DVT with non-recanalized segment. You can see, may see the femoral and distal veins are recanalized well. but there may be a segment
Right.
of 4 to 5 centimeter which is not open. And those particular patients, if they keep on complaining of bursting pain or edema or tiredness, we can consider for venoplasty and stenting.
Okay. Thank you. Vishnu?
Yes, starting heparin or low molecular weight heparin within the first 24 hours of diagnosis, the incidence of recurrent venous thromboembolism has been reduced from first 3 months from 25% in the first 3 months from 25% to 5%. So coming to side effects and toxicity of heparin and low molecular weight heparin, bleeding is a major side effect, which is more in elderly females associated with renal failure. There can be anaphylactic reactions due to heparin of animal origins. And local effects due to subcutaneous or injections of low molecular weight heparin include pain, local irritation, erythema, injection site ulcer. And special reference to heparin-induced thrombocytopenia, which can be with or without thrombosis. It is an immune-mediated reaction resulting from irreversible aggregation of platelets, which can be treated by stopping the heparin and the use of direct thrombin inhibitors or fondaparin. Sir, coming to oral anticoagulants of coumarin derivatives, warfarin, which is an abbreviation for Wisconsin Alumni Research Foundation, and ARIN, which is the suffix taken from coumarin. It has 100% bioavailability. It has a longer half-life of 36 hours, and there is a lack of urine excretion, but the onset of duration is 36 to 48 hours, and the duration is 2 to 5 days of activity. The mechanism of action is blockade of the enzyme vitamin K epoxide oxidoreductase and causes decreased clotting activity of the factors 2, 7, 9, and 10, which are vitamin K dependent clotting factors. The dosage is, the standard doses are given 5 to 10 mg. We usually initiate warfarin on day 1 or 2 of low molecular weight heparin or unfractionated heparin therapy, and we overlap warfarin and parenteral anticoagulant for at least 5 days until desired INR of greater than 2 and 2.5 to 3 is maintained for 24 hours. Then we discontinue heparin because the rationale for overlapping warfarin and parenteral anticoagulants is because warfarin inhibits the synthesis of future factors with no effect on already found factors. This causes an imbalance between the procoagulants and anticoagulants. The factors which are already present in the blood supply are not inhibited by warfarin. It takes duration for inhibition of the future factors, which causes a hypercoagulable state, and there can be further progression of the thrombus. We check INR after 2 days and adjust the dose accordingly to the expected results. Typical maintenance dose ranges between 5 to 7 milligrams per day. So this is the INR range and the duration. In conditions and the time of duration, this is the range and treatment of therapy. Surgery provoked DVT or pulmonary embolism, the time of duration is 3 months. In a patient with transient risk factor induced DVT, which can be reversible, like pregnancy or patient on oral contraceptive pills and hormone replacement therapy, the time of duration is for 3 months. First, unprovoked proximal deep vein thrombosis or pulmonary embolism with low or moderate bleeding risk. The treatment is extended consideration with periodic risk-benefit analysis. Patients with first unprovoked proximal DVT and pulmonary embolism with high bleeding risk, the time of duration is 3 months, and depending upon the extent of the deep vein thrombosis, the duration can be extended. Patients of first unprovoked distal DVT, regardless of bleeding risk, the time of duration is for 3 months with a maintenance of therapeutic INR between 2 to 3. If patient is having a concomitant unprovoked DVT or pulmonary embolism with low to moderate bleeding risk, the treatment can be extended. Patient with second unprovoked DVT or pulmonary embolism with high bleeding risk, the treatment of the time of duration is 3 months, and then depending upon the Doppler venous studies, the time of duration can be extended. And the role of the therapeutic range is to maintain a therapeutic INR of 2 or 3 or 2.5 to 3. Coming to toxicity and side effects of warfarin, hemorrhage and warfarin necrosis usually seen in thighs and breast and lateral flanks of the abdomen. Osteoporosis, calcification of walls and arteries, Purpurto syndrome, which is usually seen in great toes due to accumulation of blood clots in the distal capillaries within 3 to 8 weeks of commencement. Reversal of warfarin action and toxicity. When a patient comes with warfarin toxicity and bleeding, We omit the first 1 to 2 doses or hold warfarin and monitor INR. We adjust warfarin dose accordingly. If the INR is in therapeutic range and we want to reverse the action of warfarin, simple discontinuation of the drug for 5 days is usually enough to reverse the effect and cause INR to drop below 1.5. If patient's INR is between 4.5 to 10 and patient has no bleeding diathesis, according to the Rudolph ACCP, American College of Chest Physician guidelines, they suggest against routine use. They are advising to stop the use of warfarin, and they suggest considering vitamin K1 2.5 mg per orally once. If INR is greater than 10 and patient has no bleeding, the guidelines recommend vitamin K1 and suggest 2.5 to 5 mg per oral once, and reduction of INR is observed within 24 to 48 hours. INR should be monitored and additional vitamin K should be given if it is required. Patients with minor bleeding and any elevated INR levels, consider a 2.5 to 5 mg per oral once of vitamin K1 and repeat if it is needed after 24 hours after a re-establishment of the INR of the patient. Patients with major bleeding and elevated INR, the guidelines say that recommend prothrombin complex concentrate, vitamin K1 5 to 10 mg IV, which is diluted in 50 ml IV fluids and infused over 20 minutes. Fresh frozen plasma and recombinant factors 7A is also to be given. Sir, these are the doses for vitamin K1. Perorally, it can be repeated every 12 to 48 hours and intravenous route every 6 to 8 hours. Factor 10A inhibitors, indirect factor 10A inhibitors are fondaparinux, which is a synthetic pentasaccharide molecule. Efficient inactivation of factor 10A is obtained by the fondaparinux. It has a longer half-life of 15 hours, so once daily subcutaneous dosing is enough, and it has a high potential in using in case of heparin-induced thrombocytopenia. And direct factor 10A inhibitor is rivaroxaban, which is a highly selective direct inhibitor for factor 10A. The dosage usually includes 10 mg, which is used as a prevention for venous thromboembolism in adults in patients undergoing elective hip or knee replacement surgeries. A dosage of 15 mg or 20 mg is used for prevention of stroke and systemic embolism in adults. And patients with non-valvular atrial fibrillations used as a treatment for DVT and pulmonary embolism and prevention for recurrent DVT and pulmonary embolism in adults. Direct thrombin inhibitors, there are two types, the parenteral ones and the oral direct thrombin inhibitors, bivalent and monovalent. Bivalent including hiridine, lipiridine, and bivalirudine. Monovalent direct thrombin inhibitors including argatroban. The oral direct thrombin inhibitor is dabigatran. It is used in the treatment of deep venous thrombosis and pulmonary embolism in patients who have been treated already with a parenteral anticoagulant for the initial 5 to 10 days. Sir, anticoagulants of coffin thromboembolisms. If the patient is symptomatic, then short-term anticoagulant therapy for 3 months is indicated. If patient is asymptomatic with an isolated coffin DVT, then there is no requirement of any anticoagulants. Surveillance ultrasound studies for 10 to 14 days to detect proximal extension, and patient should be advised compression stockings. And if there is severe edema, then intermittent pneumatic compression devices can be given.
So you mean to say that if there is no symptoms and there is DVT, you don't need to treat it?
Yes, sir. Surveillance is to be kept upon the patient, sir. Every 10 to 14 days, we can do a Doppler, venous Doppler, to see if the venous thrombosis is extending or if there is any fragmented segments which are going proximally.
Rujal bhai?
I would disagree with this. Everybody and anybody in the world, if their patient has cuff and DVT, you have to consider for anticoagulation. I don't know which guidelines say this, but
yeah, I believe you.
Yeah, the thrombus propagation and thrombus, continuation migration is quite important. Many of the cuff and DVT, they will embolize directly to the heart, and we don't want the soleal veins or cuff vein to develop larger quantity of clot. So compression and anticoagulant should be given. In theory, you may check it whether it's confirm or not, but in practice nobody will do this.
Sure. Yeah. Okay.
So
Vishnu?
Coming to thrombolysis,
Continue.
systemic thrombolysis is not usually indicated in deep venous thrombosis. catheter-directed thrombolysis is the mainstay treatment for thrombolysis. The American Heart Association recommends catheter-directed thrombolysis for the first line as a first-line treatment of carefully selected patients with acute iliofemoral DVT, which is acute, which is less than 21 days within onset of symptoms, and limb-threatening compromise and a rapid thrombus extension or symptomatic progression despite anticoagulation. The SIR, the Society for Interventional Radiology, recommends catheter-directed thrombolysis for patients with acute iliofemoral deep vein thrombosis in ambulatory patients with low bleeding risk and lifelong expectancy. Patients who are highly symptomatic with subacute and chronic iliofemoral deep vein thrombosis. Patients who are acute or subacute having IVC thrombosis. Limb-threatening conditions such as phlegmasia alveus cerulens, SIR recommends catheter-directed thrombolysis. Thrombolytic agents, these are fibrin-specific and non-fibrin specific. Fibrin-specific include alteplase, which was the first recombinant tissue plasminogen activator, and retiplase, which is a recombinant tissue plasminogen activator, and tenecteplase. Non-fibrin specific thrombolytic agents are streptokinase, urokinase, and pro-urokinase. Catheter-directed thrombolysis for acute deep vein thrombosis. The basic steps in performing CDT and related procedures are the establishment of a venous access using ultrasound guidance, catheter venography to map the extent of thrombus, intrathrombus delivery of a thrombolytic drug using a catheter. This may be accomplished via slow infusion through a traditional multi-side hole infusion catheter or an ultrasound emitting infusion catheter, or by bolus drug delivery. Dispersion through a catheter-based drug delivery.
So from where do you enter? Vishnu, where
Yes,
do you enter?
Sir, it can be entered
US?
from the, from the distal vein. Venous access should be identified via ultrasound guidance, and then, sir, distally we can enter.
Wait. I think, Shujal, can you just highlight some points about this? I think that will be easy.
Usually you enter by the popliteal vein, popliteal fossa. The vein, artery, and nerve are superficial to deep, vein, artery, and nerve, right? So if for left-sided procedure, you have to make the patient prone, and you will put an ultrasound probe. The first structure would be a distended vein, so your needle entry would be very easy. So, and you don't need thrombolysis for your soleal veins. Okay, so popliteal, if you puncture the popliteal, you will see the whole of the popliteal, femoral, iliac, and IVC. So most of the time it is popliteal vein DVT, and very rarely it is femoral vein. So you will make the patient supine and puncture the femoral vein back. Otherwise, it's popliteal vein. If you, sir, if once he finishes, I can show one or two images which I have, if possible, so that the picture photo.
Fantastic.
Right.
Yeah. Vishnu, make it a little fast. I think that would be a good approach.
Yes, sir. Sir, these are the images showing catheter-directed thrombolysis, sir. In the first image, the venous thrombosis is identified in the proximal iliac, common iliac vein, and then the catheter is placed after.
Keep the images, Vishnu. Keep the images. Sujal bhai is already showing us, so that is better.
Okay, sir. Sir, in conclusion, CDT also reduces risk of recurrent DVT more than anticoagulation therapy alone. In carefully selected patients, CDT may prove to be a cost-effective adjunct to traditional anticoagulations. Patients with acute iliofemoral DVT and long life expectancy are particularly likely to benefit. The main complication is bleeding, of which the majority is confined to the venous access site, which can be controlled. And close clinical monitoring is necessary during CDT to minimize the risk of the patient. Intracranial bleeding is a rare complication, but it's which is less than 1%, but it is a potentially lethal complication. Sir, replacement of venous valves, percutaneously placed biprosthetic venous valves are under development, which is a new thing, and may provide a minimally invasive therapy to the long-term complication of post-thrombotic syndrome due to valve destruction. So coming to percutaneous mechanical thrombectomy, this is the one area where its use remains in those patients with phlegmasia and cerulear dolens and venous gangrene. Percutaneous mechanical thrombectomy in combination with anticoagulation can debulk the most of the occlusive iliofemoral DVT to provide early restoration of venous flow. The device that we usually use is an angiojet device. It combines an alternating high pressure irrigation with high suction and alternating at 60 times per minute. So this is the angiojet device with a console. The console monitors and controls the system. The catheter is introduced into the vein after insertion of a sheath with a plastic catheter. The console energizes the pump and sends a pressurized saline to the catheter tip. The saline jet, which causes lysis of the thrombus, and the saline jet travels backwards, taking the bits of thrombus along with it using a suction effect, and the thrombus is drawn.
This is like basically creating an agitator, right?
Yes, sir. Yes, sir.
You are agitating the clot and suctioning it, correct?
Yes, sir. Thrombus
Okay.
is then drawn into the inflow windows, and the jets push the thrombus back down into the catheter. And then the thrombus is evacuated and then disposed. The complications include combination with thrombolysis and anticoagulation likely leads to an increased risk of bleeding complications when compared to conventional percutaneous procedures. Most common complication associated with use of percutaneous angiojet is of hemolysis. Almost all patients experience some degree of hemoglobin increase and resultant hemoglobinuria, but there has been no evidence of patients developing acute kidney injury due to the hemoglobinuria which is developed due to angiojet. Additional complications seen with mechanical thrombectomy is particularly in the coronary circulation is that of bradycardia with angiojet use. So coming to thrombectomy, prior to introduction of intravenous heparin, surgical thrombectomy was the only effective means for treating a symptomatic low-limb DVT. Open surgical thrombectomy is associated with significant blood loss during the procedure. Rethrombosis occurs in many patients despite post-operative anticoagulation.
Is it done nowadays?
Sir, in chronic conditions which is proximally evolving or patient with chronic post-thrombotic syndrome, then thrombectomy can be done in iliofemoral veins.
Okay.
You can't do
Yeah, wait. Yes, Rujal bhai.
You can't do it in chronic patients. It has to be done in acute massive thrombosis where the limb is threatened. Chronic cases, you will not get anything in the Fogarty. Right.
Okay. Okay, Vishnu, anything else or we'll ask? Okay, yeah, IVC filters. Continue.
Sir, inferior vena cava filter placement is recommended when there is a contraindication or a failure of anticoagulant therapy in an individual who is at risk for a proximal vein thrombosis or pulmonary embolism. It is also recommended in patients with recurrent thromboembolism despite adequate anticoagulation for chronic recurrent embolisms or with pulmonary hypertension. Sir, the American Heart Association recommends the placement of IVC filters includes confirmed acute proximal DVT or acute pulmonary embolism in patient with contraindication for anticoagulation, recurrent thromboembolism while on anticoagulants, and patients who have active bleeding complications requiring termination of anticoagulation therapy. The relative contraindications are large free-floating iliofemoral thrombus in high-risk patients, propagating iliofemoral thrombus while on anticoagulation, and chronic pulmonary embolism in patient with pulmonary hypertension and call pulmonary. So these are the IVC filters. Sir. Role of fasciotomy and need.
Vishnu.
Sir, yes, sir.
Go back to the relative contraindication. They are not relative contraindications.
Sir, relative indications. Yes.
Yeah, they are relative indications.
Indication. Yes. Role of. Yes,
okay. I think Vishnu, wait a second. I think wait. Before you go for fasciotomy, Sujal bhai, what? Okay, fine. Okay, complete.
Yes, sir. Sir, role of fasciotomy and need for amputation.
Vishnu, complete, sir.
Yes, sir. Yes. Sir, fasciotomy has a limited role in the presentation of an acute DVT. Patients who develop acute compartment syndrome as an extension of DVT, fasciotomy is indicated in such patients to relieve the intracompartmental pressure, which helps the further progression, which helps in establishment of venous flow and prevents extension of thrombus and limb ischemia due to impaired venous drainage. Patients with definitive venous gangrene and an unsalvageable limb, amputation of the limb may be necessary. Sir, thank you.
Hello.
Sir, done with the
Can I make a comment, Vishnu?
Sir.
Excellent presentation. Very nice. All the details, lot of details covered, and almost we have not left anything for, which is untouched. So brilliant presentation. If you know this much in MS general surgery, you will, excel in life. Right? We never knew this much.
I hope, no, sir. But this, even 10% will help a lot in our patients.
Super detailing. So I would prefer if you can mail me this presentation. Sir, can you manage to send me this? He has covered everything.
Yeah, sure. Yeah, sure.
Very nice. Very nice.
Thank you, sir.
So almost everything is covered. The venous thrombectomy is indicated in very rare cases I have done only one patient, and that case was selected for best case presentation in European Vascular Forum. I won a prize when I presented it there, because a lot of senior surgeons also, they don't get much of this open venous thrombectomy, and fasciotomy, as you said, is very much required in those cases. Just this a few slides about CDT. I can share. If you stop sharing, I can share my screen.
Okay, sir. Yes, sir.
So can you see my screen? Okay.
Yes, sir. Yes, sir.
So why CDT is required, as you said, rightly said, that in case of, sorry. A lot of, I'll come to that slide. Okay. So CDT is catheter directed thrombolysis. Many of the proximal DVT patients develop post-thrombotic syndrome after 4 to 5 years or 10 years. Actually, in past, a lot of physicians were not considering for anti-thrombotic or anticoagulants, and then this wave for CDT was there before 10 years, as madam said. But for these are the post-thrombotic kind of syndrome. You must have seen in your OPD that these patients come because of they have not got proper treatment before many years, right? So now thrombolytic therapy, as you said, CDT is better than systemic thrombolysis, and it should be tried up to 21 days. You can try it, but mainly within 14 days. And patient should have good bleeding risk, good general condition, life expectancy of 1 year or more, and low bleeding risk. How we do it? Once we select the patient, consent and prognosis should be discussed. This is a photograph showing a patient made prone. This is a popliteal venous access. It is very easy to get a popliteal venous access. You put your probe in axial section and you get a puncture. Then this is a 7 French sheath with a Craig McNamara catheter. As you had mentioned in your slide, that there are catheters, multiple side holes. The main purpose of putting this is you want to give intrathrombus lacing. It is not in the open veins. It has to go through, as shown in this figure, that iliac vein is occluded, and here this femoral vein in the thigh is occluded. Thrombus is entered with this wire, and catheter is kept inside, and the tip of this catheter is placed just below the proximal extent of the thrombus. So once you start your bolus dose, the Actylize or your any thrombolytic agent will start going into the thrombus, and then you repeat. You give a bolus, then you give a continuous infusion, and many a times, actually in this slide, some of the images are hidden in the back of this slide. I can't actually change it, but we do thrombo aspiration also. So once your bolus is given, after 1 hour, we do negative suction by syringe and pull and push the catheter large diameter. You will see, you will get a lot of clots aspirated. So that will reduce your thrombus burden, and then you continue infusion for almost 24 hours. As shown in this figure, this kind of thrombus will be lysed. And similarly in this figure, once you achieve this kind of clearance, you can end the procedure and put the patient on anticoagulation, right? And what this open venous thrombectomy, what you had mentioned is, in this figure, it is shown as a catheter is placed inside the IVC for prevention of thrombus moving into the heart. But nowadays we put IVC filter, which is a temporary and retrievable filter. Then we do thrombectomy, and the filter is removed at the end of 1 month or 2 months, right? So most of the time you don't put a long-term filter, because once you put the filter, there are chance of recurrent DVT or DVT on the opposite side also. So don't go into the lot of filter insertion. In future, we may see this kind of, as you have discussed, that angiojet is quite frequently used. And two important point you mentioned is hematuria and hemoglobinuria and this bradycardia. These are very important, right? And it's like a third thing is it is very costly. So in future, devices may come that 2 balloons and with a rotating wire trellis kind of device. And that's all. I think you have covered everything. So I'll stop sharing here. Thank you.
Sujal bhai, one question from my side. How long does your procedure last? you put in a catheter, you keep it for 24 hours, 48 hours, or it is in
Sir,
hours?
it is maximum 24 hours, sir. At the end of 24 hours, you will get the clearance. Whatever maximum clearance you would achieve after 24 hours should be good enough. So there is no meaning in continuing for 48 hours.
Okay. And I think another question is exact. If I talk about the indication, I think iliofemoral or proximal ones, which are
Massive proximal DVT. Yes, that is
massive. Yes. Okay. Yeah. Okay. Fine. Fine. Vishnu, any other residents? Any questions for Sujal bhai? Ma'am. Okay. So I think thanks a lot, Sujal bhai. I mean,
sir, I have a question. Just
yes.
one. Vishnu, where did you collect all these details? Is it some textbook or some presentation? Where did you get all these details?
Sir, from the ACCP guidelines and some from Medscape, sir. Medscape, they have given information about.
Very nice. Keep it up. Sir, he's a brilliant student.
Thank you.
Thank you.
Thank you. Thank you, Sujal bhai. So I think that is it for the day. We'll leave. Sujal bhai, the most important part of why I wanted your part in the presentation was that because we keep this on YouTube link so that it completes the presentation for anybody who watches it later on. Thanks a lot. Thank you, Nina Ben. We'll leave then. Thank you.
Thank you.
Thank you,
Thank you, sir.
Vishnu. Good.
Sir, thank you, sir.